Welcome to another Mast Cell 360 Live. I hope everyone had a nice weekend. Today, everyone is in for a special treat. We have an expert guest. Some of you may be familiar with Dr. Kelly McCann's work as we co-hosted our last Mast Cell Summit with her. But if you're new to this community and not familiar with Dr. McCann, I'm going to introduce her in just a second. So we'd love to hear in the comments, where are you guys tuning in from, and were you able to catch the last Mastering Mast Cell Summit with Dr. McCann? And before I bring her up, just some quick disclaimers. This presentation is for informational and educational purposes. It is not meant to treat, diagnose, cure, or prevent illness. Be sure to discuss any health recommendations with your healthcare provider. And some links that we share during this presentation or on our website are affiliate links. This means Mast Cell 360 may take a very small commission if you purchase through our link, and we only recommend products that we love and use personally or use in the Mast Cell 360 practice. All right, so today's live is called Mold, MCAS, Oxalates, and Clotting, What You Need to Know. Right, so we're going to be discussing some of the intersections of chronic illness, MCAS, connections to oxalates, mold, and blood changes. And if we have time, we will do a live Q&A, so please keep your questions on the topic of today's live. Please refrain from asking in-depth medical questions as we're unable to answer those. And please only ask your question one time. We do have staff behind the scenes, Cam and Zach, are looking out for those questions and marking them for us. So we'll get to as many of those as we can if time allows. All right, so in addition to Dr. McCann, we will have our lead practitioner, Kimberley, joining us for this amazing discussion. But for those who aren't familiar with Dr. McCann's work, she's an acclaimed and compassionate physician specializing in functional, integrative, and environmental medicine. She is trained under Dr. Andrew Weil and is certified by the Institute of Functional Medicine and also board certified in integrative medicine by the American Board of Physician Specialties. She practices in California at the Spring Center. All right, so let's welcome Kimberley and Dr. McCann to the stage. Thank you guys so much for being here today.
Thank you.
Yeah.
Thank you for having me. I really appreciate it.
We enjoy having you. All right, let's jump in. Dr. McCann, would you like to start us off?
Yes. So as many of you know, suffering from chronic illness, it's multifaceted. We were just talking about this backstage, that very rarely there's that one single magic bullet that's going to fix everything. And so people have many symptoms, many sensitivities, many triggers, and there's a variety of root causes. We'll talk about mold today as one of the root causes of MCAS. We'll talk about oxalates as well. And then that interplay between triggers and sensitivities and how they're all intermeshed together. And then, I always want to remind us that we're more than just our biology. It's not just about fixing that pathway or that metabolic dysfunction or getting rid of the physical triggers. We also really have to pay attention and deal with our emotions, our thoughts, our beliefs about ourselves, about our situation. And this is because in my practice, I've really found that we can do all the things physically. We can take all the supplements. We can, make our houses mold-free, all of those things. But if we don't deal with the internal ecosystem of our beliefs, of our emotions, and our responses to stress, we're not going to really, truly heal. So I think that that's important to remember.
Yeah, thank you. Okay, so we have many people joining this community who are actually fairly new to MCAS. So if you can kind of go over a little bit of review, and Kimberly can share like what we see in our clinic as well.
Absolutely. So we know that MCAS is a multi-system, multi-symptom condition that is often triggered by a variety of different things. I'm sure, I know I've talked with Beth about this many times, that mold and mycotoxins is one of the biggest triggers for MCAS. And certainly if people are perpetually hypersensitive, that is the one thing that we have to go looking for, because it is a huge, huge trigger. And then, of course, trauma and chronic stressors, adverse childhood events, as I was alluding to before, those often set the stage for people who are much more likely to develop MCAS. And even if you didn't have the worst adverse childhood events, we can be impacted by even neglect and some of the things that don't seem so traumatic. So you don't have to have a childhood growing up with drug addicted parents to have adverse childhood events and to have those things impact your nervous system and manifest as MCAS. Food, of course, is one of the biggest triggers, and I know people struggle with food in their intakes as well as allergens on a regular basis. I think it's also important to recognize that we live in a toxic chemical soup. There are hundreds of thousands of chemicals that we're exposed to on a regular basis, and the list is very long. So the more that we can do to clean up our food choices, eat organic, avoiding pesticides, looking at our personal care products, our cleaning products, and then all of the things in our houses. So many of the building materials are filled with flame retardants, and there's plastic everywhere. So doing our best to limit these chemical toxins in a toxic world will lower our bucket of triggers. EMF is another thing that oftentimes people don't think of. We are also bathing in a sea of EMF with Wi-Fi and 5G everywhere. And for some people, that's a significant trigger of their MCAS. Infections, too, I'd say number one would be mold, and number two would be Bartonella or cat scratch fever, which can sometimes be transmitted by a tick, but not always. We can get cat scratch fever from cats and scratches and bites. And then there are many other vector-borne illnesses. Vector-borne simply means that it's transmitted by an insect. And then, of course, we can get fungal infections, often from mold colonization, and anything that drives inflammation. So COVID viral infections, I see a lot of patients this year getting influenza, and that's leading to prolonged viral inflammatory states and making things worse. So lots and lots of triggers. And so it is putting on your, Sherlock Holmes hat to try and figure out what are your triggers and how can you lower your burden.
Yeah. Kimberly, do you have anything to share, like what we see in clinic?
Yeah, one big thing is just I've found that you cannot out supplement or out medicate those triggers, and it's so important in terms of healing to get and find those different triggers so that things can calm down. I think that's an important thing to do, and then as well as not just going after if it's an internal trigger, just not going after to kill an infection or something like that. Being mindful of if you have things upregulated, going in, making sure the mast cells are calm before you're going after something.
Yeah, I think with our sensitive population, and I'm going to bring up the nervous system because Dr. McCann mentioned like the trauma and the adverse childhood events. You don't have to, often those don't have to be the big T trauma. Sometimes it's the little T trauma. And so we do need to start at a place where, when someone's so sensitive, you can't even address detoxing chemicals or detoxing mold until we address some of those internal triggers. Can be really, really helpful to start like with our very sensitive population. Going back to basics.
Yes, absolutely.
Yeah. Okay. So, it is Mold Month for us. And we've done some extensive talks on mold and MCAS recently. We're not going to go as deep into that today. You can go back to our live from March 3rd. And of course, we have so many other resources on our website. But today we want to talk about some of the issues that we see and Dr. McCann sees that are often considerations with mold toxicity and MCAS. So Kimberly, do you want to start us off with something that we've been seeing a lot of in the clinic? I'm going to go to the next slide. You'll know what I'm talking about in just a second, everyone.
So yeah, seeing more and more people with almost like a hidden oxalate issue going on underneath it. And the thing to know, and I'll explain a little bit what oxalates are, and it's not just in your food, but it is in the food too, and it's just an overwhelm in the body when we're trying to detox them. And the thing to remember about the oxalates is when we are detoxing and we're detoxing oxalates, it's really hard on the body. Like you have to think about, these are like shards of glass. I tell people they're physical, like because they're oxalate crystals. And if you ever look at them under a microscope, they're really sharp. So I'm like, have so much compassion for yourself when you're detoxing these. And it is very much about finding the right rate of detox, because we want to detox them, but we don't want to be at such a high rate that you're overwhelming your body and causing a lot of pain and things like that. But they just do a number on us when they are detoxing. So what are they? Oxalates are oxalic acid, is an organic compound that's found in many plants. And sometimes we go and we eat super, super healthy because we're trying to go low histamine, but we end up loading up on some foods that are just too high oxalate. So the highest oxalate foods to be very mindful of, if it's something you're eating a lot of, is sweet potatoes, spinach, beets, plantains, chocolate, almonds. I often see people go dairy-free and then do almond flour, almond milk, all the almond products, which are so easy to overeat. Rhubarb is another one, and Swiss chard as well. So those oxalic acid that's in those plants bind to minerals and produce those oxalate crystals. And it's not that there's anything super bad, but it's just a part of the plant that's its defense system. And if we're overdoing it, somebody, I was guilty of this, doing almond milk with spinach in a smoothie is not an ideal thing to do. And the mold adds to that oxalate load as well. Do you want to add anything, Dr. McCann, on that?
Let's see. So, I think it's important to remember that the oxalate crystals really can irritate and damage those tissues, which triggers mast cell release and other inflammatory mediators. It contributes to leaky gut. And also can cause some mitochondrial issues. Some people are genetically predisposed to have more issues with oxalates. And then, the molds that are often triggering the mast cells, some of those molds can make oxalates as well. Somewhere here I have a list because I can remember all of them. The aflatoxins, particularly aspergillus, can wrong list, sorry, can make some oxalates. So it's this combination of things that coalesces in somebody who has oxalate issues. And then, as you mentioned, reducing those oxalate load in the body over time is super important, to be very conscientious and make sure that people don't feel much worse.
Yeah. The thing I'll add there is don't go cold turkey on a food if you're eating a lot of it. That's the biggest mistake. I see sometimes people will go, also want to go carnivore or keto, which I get. But if you were eating a ton of these foods and you stop, you can have an oxalate dump, which can do a number on our body and then just regulate the mast cell and do some real damage on the way out.
Yeah. So Dr. McCann mentioned some of this, but high oxalate diet. Kimberly, do you want to share a little bit more?
Yeah. So what are contributors to it? So high oxalate diet, which might be in the past because those can store in the body. Leaky gut can contribute to it. Just mold can add to the leaky gut. And then if you have leaky gut and you're getting oxalates into your bloodstream, that's going to irritate your immune system, of course. Dysbiosis is huge because there are certain strands of gut bacteria that help break down those oxalates. So if we've had a lot of SIBO and done a lot of antibiotics and things like that, that really can kill off those things you need to break down oxalates. Glyphosate exposure can actually lead to it as well, can be a contributing factor. Genetic variants leading to overproduction of oxalates, low B1 or B6 we see a lot if you've really restricted your foods or your body has done a lot of detox. You might be low on those. Low sulfate is another. And then as Dr. McCann was alluding to, colonization of like Aspergillus in your body, that mold colonization we talk about can add to that oxalate load as well.
Some of the symptoms to think about, if you have a lot of skin reactions, kind of itching, hives, rashes, which a lot of mast cell patients have, and that could be oxalate issues. It might be something else, but certainly you want to think about oxalates if you haven't figured that out yet for yourself. And then lots of GI symptoms. I know there's so much overlap, it makes it really confusing. Interstitial cystitis. So once those crystals end up in the bladder, they are going to be very painful. Sometimes patients have had muscle aches and pains and joint pain. So those crystals can end up in the muscles, in the joints. Dysautonomia symptoms or worsening POT symptoms can be a sign that oxalate issues are a problem, or increased brain fog, anxiety, irritability. So clearly, there's so much overlap between MCAS and oxalates. So looking at the diet and saying, am I eating all those foods, or did I get worse when I took those foods out? It might be a clue. And then it can be looked at in terms of testing. There are some organic acid tests that look at oxalates, but it's not a perfect test, because if the oxalates are in the tissues and they're not coming out in the urine, you're going to have a false negative test, right? So important to recognize that the oxalates could still be in the tissues and causing inflammation and triggering mast cell and all of these things that we're talking about.
Yeah, I have seen that recently with clients where it's like on their organic acids test, it's like low normal. And like a few months later, they're having kidney stones. So
right.
It's like that point in time is the only time, like it wasn't detox at that time, but they're just so random, I feel like, when they detox.
Yes. So that would be the other big sign. If you have kidney stones, a family history of kidney stones, there might be some oxalate issues there. And always try and catch those stones to get them analyzed if you have them.
Yeah, so I onboard all new clients in our clinic, and Kimberly and I have been having these discussions because she's teaching me so much about like what signs to look for. And so as clients are coming in on their, kind of their roadmap and onboarding session, I'm evaluating and asking these types of questions like, oh, do you have these symptoms, or did you experience them in the past? Because sometimes it's like, well, maybe they already dumped the oxalates and now their gut is so trashed because they did a big dump. So I'm seeing a lot of like mineral deficient, like extreme thirst lately from like mineral deficiencies of just being so depleted from possible oxalate dumping. There's just a lot going on, and we're seeing more and more. And I think, oxalates is kind of like the new frontier, I think, of nutrition, the nutrition field, and there's just not enough research on it yet, especially with that connection to the mold.
The other thing is I have clients who'll be like, all of a sudden I'm craving everything milk, calcium, and I'm like, the body uses that mineral to detox them. So kind of leaning into that wisdom of the body a little bit around those things, or looking at, did they have a big oxalate dump, and are they mineral deficient now?
Right. So you can take calcium citrate. So it would be the calcium magnesium citrate that would help bind up those oxalates. So that's a possibility. And there are certainly some supplements out there that can help with binding those oxalates.
Yeah, and we usually do calcium MCHA just because we're worried about the citrate with the histamine piece. But adding in a little bit of calcium for sure.
Yeah. Okay. see so Dr. McCann, we talked a little bit about like the mold exposure influencing oxalate burden on the body, and binding that with some calcium possibly. Do you have any other strategies that you use to support people dealing with MCAS, mold toxicity, and high oxalates in your clinic?
Well, I mean, I think we probably do things very similarly. We have to calm down the mast cells before we can really aggressively go after mold treatment. And when there's an oxalate issue in there too, it's that diet piece that's most effective at lowering the oxalate burden slowly over time so that people feel better. And the rate at which they do that really depends on them. So potentially working with a nutritionist, I often have patients get Sally Norton's book, which I think is very thorough. What's it called? Toxic Superfoods. to really help them figure out how to slowly reduce the oxalates in their diet. I think one of my favorite things that I love to give my mold and mast cell patients, if they're able to tolerate it, is phosphatidylcholine. Phosphatidylcholine is a building block of every cell in the body. And now some of my mast cell patients are so sensitive that they can't start there, but I do find that some can, and that is a goal for many of us, is to get them on phosphatidylcholine. As a building block of every cell, it's going to, here's my little analogy. So my pen is the mold toxin and my fingers are the cell. If the mycotoxin is sitting in the cell and we take PC, and PC is the building block of the outside membrane, you will pull out the toxin and heal the cell. Now the mycotoxin is in the extracellular matrix outside of the cells and needs to be escorted to the liver and or the kidneys to be removed. But that PC now can heal the cell, it can heal the mitochondria, and those cells can start to function a little bit more effectively. The mitochondria can potentially kick back on. So I love PC as part of my mold and mast cell protocols and recovering. And it doesn't really matter if it's other environmental chemicals as well. It's really helping heal those cellular membranes and healing at the cellular level.
Yeah, thank you. Okay, so how does clotting fit into all of this?
It's not exactly straightforward, but so I can go over this if you want, or you can go over it.
Oh, yeah, go ahead.
Okay, so what is clotting? Clotting is the way that the body stops bleeding. So when you cut yourself or you have an injury, it's going to form this glue matrix that will stop the bleeding. And we need that to survive. Platelets and then the red blood cells, they all stick together. And there are specific proteins that are in the blood called clotting factors that are super important at creating that mesh. And then once the wound heals, the body can break down the clot and the blood can flow normally again. And we have this imbalance, coagulation or clotting, and breakdown of clot is called fibrinolysis. And we want to be able to clot appropriately when we get injured and break down our clot when things are all better. And what I found with MCAS and mold is that there can be a clotting issue. Now, the clotting issue may be because of one of the triggers, or it could be a genetic predisposition. And sometimes with MCAS, because it is such an unusual combination of things, some people can get bleeding as a presentation of MCAS, but I do see a lot of clotting, in part because I do think that the mycotoxins impact coagulation. Aflatoxins in particular can cause abnormal clotting, but it can also cause hemorrhaging too. So it is this double-edged sword. I think the important part is to recognize that MCAS is an inflammatory event, and that can either trigger increased bleeding or increased clotting. And mold is driving oxidative stress inflammation and can also lead to clotting or breakdown of clots. So I think that's pretty much what I want to say on that slide.
Yeah. The only place I was going with that was also thinking about when mast cells let go, they're letting go of all these, intermediaries, right? Like heparin and things like that, which can add, right, in addition with the clotting or not clotting, right?
Right. And, so then anything that increases inflammation on my list there, autoimmune conditions, there are conditions associated with lupus, for example, called antiphospholipid antibody syndrome or anticardiolipin antibody syndrome that are hypercoagulable or increased clotting states. I mentioned genetics. There are several different genes that increase clotting risk, such as factor V Leiden, protein C or protein S deficiencies, and then one that I found more recently called plasminogen activator inhibitor 1, or PAI1. We call it PI1 for short. And this one is not a increased clotting risk. It's a decreased breakdown of clot risk. And epidemiologically, in my patient population, I found that it is very, very common, especially if people have a family history of heart attacks or strokes. So I think that there's a problem that happens over time as people get older. They have more and more difficulty breaking down clots that will lead to an eventual heart attack or stroke. The other thing that we need to add to this list besides aging and being sedentary is hormones. So increased use of birth control pills, increased use of exogenous hormones can lead to increased clotting. So that's an important one to remember, and maybe tobacco use, but hopefully no one in this community is using that.
Yeah, that's really interesting. So would women, like menstruating women, be able to see this like in the health of their menstrual cycle at all?
Not necessarily, right? Because the blood that you're seeing in the menses is in the inner lining of, or is in the lining of the uterus, right?
Yeah.
And so it's not in the vessels anymore.
That makes sense. Yeah, interesting. Rochelle is asking, since this was kind of part of this conversation, and I'm going to botch that, so I'm going to let you read it.
Polycythemia vera. So yes, polycythemia vera is when you have too many red blood cells. And so the blood is thicker because there's more and more red blood cells. I actually have a mast cell patient who has polycythemia vera as a co-presentation with her MCAS. There is a genetic component to that too. There's a JAK2 gene that increases somebody's risk for having polycythemia vera. And it could be an increased thrombotic state, meaning that you're more likely to clot, but it may not there may not be increased proteins or difficulty with breakdown of clot per se. Because remember, we've got your platelets and your red blood cells and your clotting factors. So it could be that you have increased clotting because of increased red blood cells. But if the platelets are acting normally and the proteins are not being triggered to form clots, you might be okay. You might not be excessively clotting, if that makes sense. It's really this dance between the platelets and the red blood cells and the clotting factors. And most of the time, the reason that we clot is the proteins, the clotting factors.
Mm-hmm. Interesting. All right. Thank you for answering that. I'm just taking a quick look to see if any more questions came in that were related to this topic before we move on.
Somebody asked if there was literature or studies available on mold and clotting. And I'll tell you my new favorite best friend in AI. There's an AI platform called consensus.app that searches the medical literature. And so if you put show me the medical literature on mold and clotting, you will get out the studies that are most relevant for answering that question. It is pretty darn cool. I think it's like, $10, $12 a month. But it's if you are in medicine, it's worth it.
Yeah. AI is scary, but also amazing.
Can be super helpful.
Yeah. Kimberly, do you have anything to add or questions for Dr. McCann?
Yeah, just thinking about, the play of the estrogen and, the hormones, how the hormones are affected by the mold. And it's just such a dance, right, of everything. And the order of operations is always so tricky too.
Yes, it really is. And, I think some of it really depends on what are your symptoms, right? What are the things that are most problematic for each person when they walk in the door? And I think very simply sometimes it's like, how do I address your symptoms? How do I help you feel better in this moment when you feel so terrible? And then how can we start to identify those triggers that from those long lists, and what can we do about it now, right? So if people have a lot of hormone imbalances, or they're not menstruating at all and they're 30, right? You can get the broad diversity. I had one patient with oxalate issues, and she was in her 30s, and she hadn't had a period in, 2 years, and she had her baby like 6 years prior. So she was not still breastfeeding, and she felt miserable. She was, for all essential purposes, postmenopausal, but her pituitary hormones didn't reveal that. So we had to do things kind of slowly over time to reduce the oxalate burden and then reduce the mast cells. And interesting enough, she needed hormone replacement. So we actually did what's called the Wiley protocol to give her hormones and cyclic dosing so that she felt at least hormonally back on track while we were doing these other things. And it took, 18 months, 2 years before she was really doing much better physically. And then we started to work on the mind-body piece, and then we started to work on the spiritual pieces. And, now she's like living this life that she never even imagined for herself when she was sick. So, working with a practitioner who's knowledgeable, who can help unpack all of these many complicated links between things is super important.
Yeah. Go ahead, Kim.
Another thing I was going to just talk about was just we didn't talk a lot about the virus and how that affects clotting as well. So people with long haulers or people who were kind of vax injured are another piece, or it maybe revealed some things that are going on underneath.
Yeah, I think that's definitely part of it, and not really talked quite enough about. That I do think that people who end up injured or with long haulers or post-COVID syndrome, they had underlying issues that were not addressed, or that they didn't realize, or had not been unmasked. And, even before COVID, we would see this with our mold and our Lyme patients. People could have had a moldy basement and been totally fine, and then they got bit by a tick, and all of a sudden they couldn't tolerate the mold that was in their home that they had previously been able to tolerate. And the flip side too, right? So you have Lyme disease and you're doing okay, and then all of a sudden you go to an Airbnb that's super moldy and nothing in your life is the same again. COVID did the same thing. So it unmasked these issues that people didn't know. And, we can take a positive spin on it and say, well, fantastic. Let's dive in. Let's fix the things that we didn't know were wrong. Now we can see them and we can address it so that you don't have to go on and have cardiovascular disease and cancer and, who knows what else was going to happen downstream, because we can see that things are out of balance and we can address them now.
Yeah.
I see it as almost like that iceberg picture, where you see only what's above the water, and just we had all these things building up underneath that we just didn't see, and you might not have addressed, right? And then people get sick with something else later on. So in some ways, I see mast cell can be a gift of our body, letting us know that there's something really wrong underneath there going on, and all these layers that we need to get at.
Yeah,
absolutely.
I was going to say, so I'm going to throw out Sally's. Mold is no fun, right? And it's no secret that we see mold as one of those triggers, whether it's like the first trigger or a later trigger being prominent in MCAS. So I think you touched on this a little bit, but mycotoxins have obviously been shown to influence coagulation. So is there, what role can these mold toxins play in this process?
I mean, I think it's what we've been talking about. So mycotoxins trigger oxidative stress, which can trigger inflammation, which can trigger mast cells. And then the mast cells dump their inflammatory mediators, which then, spiral the process. And if your mast cells aren't high in heparin and therefore causing bleeding, it could cause clotting. So the way that I would think about it is, with clotting in particular, mold and mycotoxins can lead to increased clotting. And there's a number of specific mycotoxins like Aspergillus fumigatus that can activate platelets and release inflammatory mediators themselves, for example. And then you have mast cells that can do the same thing. They also have a increased clotting risk potential based on the mediators that are being produced, or increased bleeding potential based on the mediators that are being released. And then if there are chronic infections, Babesia in particular tends to create a lot of biofilm and hypercoagulability because it's a blood parasite, right? So it's in the red blood cells. And that's how those infections can persist and become chronic, is that they're creating biofilms. And then there's that genetic piece of somebody who has a hypercoagulability or increased risk for making clots. And that reinforces the biofilms, either from Lyme, Bartonella, Babesia, or I've seen it in the bladder too. Right. So there's lots of different ways that clotting can be impacted. And if we think about chronic illness as chronic inflammation, it makes sense, because inflammation can drive clotting.
I think that was a really nice breakdown and kind of like synopsis of the whole previous conversation. Okay, so what are some basic things that people can do to help encourage healthy blood coagulation process?
Certainly movement, exercise, if at all possible. Being sedentary is one of the risks for clotting. So whatever you are capable of doing, even if you have post-exertional malaise, doing a little bit every day is going to be helpful. And hydrating is super important. Some people need more electrolytes when they hydrate. There are, I always love sleep. I think sleep is restorative for so many people. I don't know if you want to slip to the next slide, because I'm talking about the next slide. Certainly we want to keep our diets as clean and healthy as possible, and avoiding processed foods, avoiding high oxalate foods, sugar. For me, I'm a big fan of gluten-free, dairy-free, meaning don't eat those things, but don't necessarily go out and buy lots of gluten-free, dairy-free products. And then some supplementation. SPM actives is a derivative of omega-3 fatty acids that is anti-inflammatory. So many people have to, well, in order for the omega-3s themselves to be anti-inflammatory, they need to be converted into these resolvins and protectants, which are already in the SPM active. So sometimes people have difficulty making that conversion, so you just take the SPM active. It might be more helpful for lowering inflammation than taking fish oil for some people.
Mm-hmm.
And there are some enzymes that can be helpful for clotting if you work with your practitioner and you find out that, yes, indeed, you have increased clotting, like an elevated fibrinogen level, fibrinogen activity, or even a D-dimer. There are some things that can be done in terms of supplements. Again, you have to be careful and work with your practitioner because some of those supplements might not be tolerated if you have very significant or if you're highly sensitive mast cell patient. But I do use a lot of nattokinase, lumbrokinase, and those can be very helpful for reducing clotting risk. So for example, I have a PI1 gene variant, that plasmalogen activator inhibitor 1 gene. I have 2 copies because both sets of parents, grandparents, have a diet of cardiovascular disease or cerebral vascular disease. So I knew I was a shoo-in for that. And I take Boluc, which is a form of lumbrokinase, every day, even though I'm not actively clotting right now.
Yeah, I had a practitioner put me on, well, she recommended Boluc, but it's a very expensive supplement. So she had a nanokinase as a biofilm disruptor. But I was like, oh, that's interesting because it's biofilm disrupting, but also helps with blood flow. So I was like, oh, it might be supporting me in multiple ways.
Yeah, so technically they're fibrinolytics. So fibrin is the building block of clot. So when you have all those proteins in the clotting cascade that are cleaving each other, if you look at, what does a clotting cascade look like? It's this pathway of multiple proteins acting as enzymes cleaving each other, and the building block that you end up with is fibrin. And so those fibrin molecules stick together, and you've got the platelets in there too. So nattokinase and lumbrokinase are the fibrinolytics that will break up those fibrin molecules.
Yeah.
And there are special biofilms that bacteria make that will, as I said, be reinforced by our fibrin layer. Now, the bacteria are not using the fibrin. I think we're using the fibrin to incorporate it there. So that's where biofilm busters can include the fibrinolytics, or they may not. And so for some patients, I use other enzymes as my biofilm busters, and then the fibrinolytic enzymes concurrently.
Yeah. Good reminder that everyone's different and always work with your practitioner.
Yes.
Always N of 1, right?
So many N's of 1. But yeah, we got to start somewhere. And then I like to encourage people to go inside and pay attention to that little voice inside of yourself that is your intuition, that is your seat of knowing of yourself, and check in with that part of you, because I think that the more that you're able to check in with that part of you, the more you'll be able to have trust in yourself and the direction that you're going in your healing journey.
Yeah, absolutely. All right.
That's been my, I was going to say, that's been my journey too. Just like, when I had really high mast cell, it was so loud, it was hard to hear. But as layers have been released, that message come through so much clearer. And it is so important to talk to the body. So that's such a great message. Listen to that body.
Yes, listen to the body and that little voice inside. Because and some people ask, well, what does that sound like, right? And it's not fear. It's not chaos. It is not what if, right? It's not that voice. That might be the devil sitting on your shoulder. It's that quiet voice inside, that knowing, right?
Mm-hmm.
How I see this show up in patients is that it's the drive to find a practitioner who will hear you, who will see you, and who you can feel confident that they're going to support you in your healing journey. It's that drive that every single one of the people on this call have to find answers, right? That you are worth finding answers, and that's why you're here, and that's why you're still seeking, and that is the drive that will get you better.
Yeah, and the message I will say there too is it's nobody can do it for you. It's a very much a you healing you.
Absolutely.
Yeah. And and staying curious, like, wow, like, okay, now I know this piece that is really interesting about oxalates, or really interesting about clotting. Is this true for me? And then really kind of learning, but with curiosity and not with fear, is huge. So
yes, I love that, Kimberly. That's beautiful. The necessity of curiosity.
And I think, like, you can call them kind of glimmers, like when you have those moments, because often when you're experiencing chronic illness, those feel very few and far between. But like when you have those little moments of curiosity, it means like you're in touch with that ventral vagal authentic self. So it can be like, that's what we strive for. It's our birthright. We can be this curious, creative, happy, sociably like connected person. But when we're dealing with chronic illness, it's very hard to feel that. So every time you do have those glimmers into that curiosity, it's like, oh, I'm on the right path, or like, oh, I'm going to find out about this a little bit more. So I agree, Kimberly. It's that curiosity piece is part of human nature and can keep us grounded. All right, let's get into some Q&As. Let's see. Joe is asking about this the binder, I can never say these, propylmannan.
Propylmannan and glycomannan. So I actually had to look this up. Thanks, Joe, for asking it early. So the propylmannan is a little bit more specialized and purified, but they're basically pretty similar. And I think they can be from similar sources as well. So the glycomannan tends to be more the fiber, and the propylmannan tends to be more of the detox binder. But I think that they can be used interchangeably.
Yeah. Okay. Let's see. What form of calcium? Oh, okay. Kimberly, do you want to take this one?
Yeah, that's the calcium MCHA, and we could probably put a link right in there.
Yeah.
But it's, I mean, I do like calcium citrate, but yeah, if the histamine is an issue for some people, it's just too much. So yeah, the calcium MCHA can be a great way. I like to tell people do it with food, because we're trying to protect your kidneys. So if you're doing it with food, and taking that calcium, it is taking it out your digestive tract and kind of protecting your kidneys. And that's what we're trying to do.
Mm-hmm. Okay, this is an interesting one. First oat test showed no oxalates and aspergillus colonization. Been on a protocol to remove mold. The retest showed no colonization anymore, but some oxalates are now showing. How curious. Oh, there's somebody used our word curious.
And they explained what Kimberly and I were talking about, that oftentimes the oxalates won't show up because they're in the tissues. And remember that when you do a urine test, you're looking at excretion. Yeah. So how cool is that? Yeah. You proved our point.
Yeah. You're starting to detox, right?
Yes,
Yeah, you
you're
got the
starting to
mold
detox.
done. So now,
Yeah.
showing that mold is a layer. And now that the mold's gone, your body feels a little bit safer to go on to the next piece. Make your
Well,
body.
and I would also probably add that I wouldn't use the oat test as the definitive test to tell you that the fungal colonization is gone, because it may miss some of the fungal markers. So, and I've seen fungal colonization persist even if the oat test is clear. So make sure to work with a practitioner and use other ways of assessing that, such as urinary mycotoxin testing or my mycolabs, microgen DX to see if there's any fungal colonization in the nose or the sinuses or the bladder, just to be sure.
Yeah, and that can be why those that mycotoxin test is still there. It's like, I'm out of mold. I detox so much. Why do I still keep having mycotoxins? And that colonization piece could be missed.
Yes, and that does require some sort of antifungal treatment. You can't just take binders and assume it's going to go away, because remember, binders don't go into the body. They stay in the GI tract, and they grab what's in the GI tract and they pull it out, which is hopefully then going to mobilize some of the toxins out of the tissues into the GI tract also, which is why you have to be careful on binders when you have mast cell and you don't feel well. If you take too many binders, you're going to feel much worse. But remember, they're not going into the body. They're not like grabbing the stuff in the tissues. They're just staying in the GI tract.
Yeah. Okay, speaking of testing, so Joe is asking, can you do anything to make the oat test more accurate, similar to like a glutathione challenge before a mycotoxin test?
Not that I'm aware of.
Yeah.
Good question, though.
Yeah.
Thanks for being curious.
Yeah.
That made me curious, that question.
I know, it was a great question. Okay, Kathy is wondering, do you use peptides in MCAS mold patients? And I can speak on behalf of Mast Cell 360. It's not typically something we go to first, but maybe your approach is different.
I haven't used a lot of peptides, but I've been using them a little bit more. I'm finding that, for example, BPC 157 and lorazepam in patients who have leaky gut issues can be really helpful. Some of my patients have used KPV as well. I don't use it a ton, but yes, I think that there is a place for peptides, and I think it will continue to grow for mast cell patients and mold patients.
Alyssa is asking if we can talk about certain types of mold that raise oxalate levels. Is it just aspergillus? What about plutonium?
Yes.
I'm not going to pretend to know everything.
Plutonium, I think, is how it's pronounced. So let's see. Somewhere I had a list. Yeah. Anyway, oh yes, here it is. That's a common oxalate producing molds. Aspergillus niger, Aspergillus flavus, Aspergillus fumigatus, Penicillium species, Chaetomium species, Fusarium species. Just about all the different mold species can produce raise oxalate levels. So yes is the answer about Chaetomium. At least that's what I found on quick Google search. So
Rebecca's wondering if hypermobility affects clotting.
Well, we know that hypermobility tends to present with more mast cell. And so, yes, it's possible. We don't really know exactly what the overlap is. The literature is still not very clear if what combination or how exactly these conditions are intertwined. But many of my mast cell colleagues do see Ehlers-Danlos syndrome, mast cell, autoimmune conditions, dysautonomias together. I think the clotting piece is an interesting question. Thank you for offering that curiosity. We'll have to look into that too.
Yeah. Okay.
someone asked about the BPC 157, nasal, oral, or subcutaneous. If you don't mind, I'll just answer that one quickly. So it depends on what the goal is. BPC 157 orally works best for the gut. If you take it by injection, it's going to be best for your connective tissue, your tissues, your joints, tendons and joints. I don't tend to use it nasally, so I can't really speak to that. But that's one of the peptides that has different indications depending upon dose of delivery.
Yeah, Margaret's asking what test was mentioned for the colonization in the nose.
So Dr. Shoemaker for a long time looked for MARCONS. MARCONS is multi-antibiotic resistant coag negative staph, a single organism. And then as a former Shoemaker doctor, we would treat it with bacitracin, EDTA, and gentamicin, bag spray, or silver, or whatever was in fashion at the time. And I didn't find that it really moved the needle for most people. More recently, there's a company that does what's called next generation sequencing. That is probably the best way to identify organisms. And the company that I'm using now is called MicroGenDx. I think there are other companies out there that do this next generation sequencing. So let me explain a little bit about it. So say you have what you think is a bladder infection. You go to the doctor and they do a urinalysis and urine culture. And that culture, they take the urine and they put it on a petri dish and they watch it grow. And you're only going to find organisms that the petri dish has the food for to grow, right? So if you're looking for a fungus and you are on a bacterial plate, fungus is not going to grow there. With the advent of PCR, which happened about the 1950s, it's been around for a long time now, PCR said, okay, I'm going to find a strand of DNA of a specific organism, like E. coli, or if we're looking in the nose, Staph aureus or whatever. And then you could take a specimen and use a probe that you knew the DNA sequence of, and you could say, is this in my specimen? Is this in my specimen? But you're only as good as the number of probes that you have. So if you have 100 probes, you can look for 100 things. Next generation sequencing flips that idea on its head and says, okay, I'm going to look for all the DNA of all the organisms in my specimen, whether that's sinus swab or bladder or prostate secretions or a wound, and identify all the DNA that's in there and match it against a library of tens of thousands of organisms so that I can find exactly what's there. So cool, right? So that's next generation sequencing. Super important to identify what's really there and treat what's really there.
All right, we have about 2 minutes left. So I want to remind everyone that it is mold month. So if you are kind of curious about where to start, we do have a course that kind of walks you through how to prep for testing, can test if, the urinary mycotoxins, and then kind of walks you through the process that Mast Cell 360 has put together. And Jenny is saying, have you taken the mold course? I loved it, made all the difference. Thank you, Jenny. We're glad that you found that resource helpful. It is currently on sale for the basic course is currently on sale for $149. So it's $100 off its typical price. And if you feel like you just need a little bit more one-on-one support, if you're located in California, I want to let you guys know where to find Dr. Kelly McCann. You can learn more about possibly working with her at drkellymccann.com. And then also, we do see clients. Some people don't know that we actually have a remote clinic. In addition to our website and free resources, we do see clients one-on-one. So we have 2 tiers, foundational clients, which is our newer, it's like a one-time or more if you need the additional support afterwards, but we treat it as a strategy session. You meet with us, we review your case, and we give you real actionable steps to kind of customize, okay, where are you in your healing journey? And then our advanced track is more our traditional comprehensive approach with I onboard with a roadmap assessment, and then you go on with a lead practitioner, and we have a multi-practitioner approach there as well. So We have 2 tiers. The foundation is just with a health coach, so myself or Cam right now. So it kind of depends. You can always start there and we can determine if you need some additional support. But I just want to thank everyone for being here today. And Dr. McCann or Kimberly, do you have any parting words for our audience?
Stay curious. That's not, just stay curious, for sure. What's true for you? And just because you hear about it in someone else or somebody else's journey, this is how they healed, that might not be true for you.
Yes, I'll second that. It is your journey. It is your healing program. It is your process. And that's where that staying curious and listening to that inner voice. If it doesn't feel right for you, then it's not right for you. And there will be the things, and oftentimes it's a combination of things. There will be no one right thing. Most likely it's going to be a smattering of things that make up your healing program, your healing package that's going to get you where you want to be.
Yeah. Well, thank you for your time, both of you. And we will see you guys next week.
Thank you so much, everyone. Take care.
Bye.
Bye.